attached onto the AED. This is the extra set of pads, identical to the one that's already attached on. All right, so step one shows you to turn the AED unit on, and I'll turn it on in a second. Step two is it shows you to rip the pads from the top so you can take off the pads from the package. We are now at step three. Step three just shows you that you still need to take it out of the blue in order for it to stick to the patient. If you do not take it out of the blue, I stick this on myself or my patient, it does not stick. I still need to take it out of the blue, and now it should stick to the patient. All right, once you've taken the packages out of the blue, we are now at step four. Step four just shows you where to put the pads on this patient. As you can see with this picture here, the pads go top right, bottom left. If you forget that it goes top right, bottom left, that's okay, because as you take these pads out here, this one clearly shows you top right, and this one clearly shows you bottom left. Now, if you forget that it goes top right, bottom left, as it shows here, you've taken this out. This one's supposed to be top right, but if you put it bottom left, and this was supposed to be bottom left, and you put it top right, essentially reversing that order, the AED will still work. The only difference is if it does elect to shock the patient and we push shock, it'll just send the shock in opposite ways. So these AED pads are known as biphase, which means it sends a shock from point A to B, B to A, essentially zapping the heart twice to give it an opportunity to restart again on its own. The AED is programmed to do two things. Once you've attached the AED onto this patient, once you turn it on, the AED is going to analyze. How do you know? It's going to say, analyzing now, do not touch the patient. It's important at that point that no one touches the patient so the AED can get an accurate reading. Once it takes that reading, the AED is programmed to look for what's called a shockable rhythm. A human heart has 4 basic rhythms. I'm sure a cardiologist will say otherwise, but the human heart, 4 basic rhythms. The regular P-wave sinus rhythm we all have in this room, we're all alive and well. We have what's called a P-wave sinus rhythm. That's the electrical shock. On the opposite side of that spectrum, what's called flatline. That's zero electrical activity. In between P-wave sinus rhythm and flatline are what's called VTAC and or VFib. VTAC is short for ventricular tachycardia, or ventricular tachycardia. That's when there's electrical activity in the heart, but it's firing really fast, not allowing it to properly refill or recoil back up with blood. Stroke volume goes down, patient goes down. If that's left unchecked or untreated, the heart will go from VTAC to then either atrial fibrillation or ventricular fibrillation, or VFib for short. That's when there's still electrical activity in the heart, but it's no longer firing in unison to create that bump contraction. As far as you're concerned, VTAC, VFib, V who cares. What's important for us to remember is that the AED will only shock those 2 shockable rhythms, which means once you turn the AED unit on and it says no shock advised, that doesn't mean that we start CPR right away. If it says no shock advised, that also doesn't mean that we just call it a day, turn the AED unit off, and go back to work. When you get a no shock advised, the AED will either say start compressions, or the AED will then say check patient, check airway, check breathing, if needed, begin CPR. If it says no shock advised and it tells us to check the patient, that's our cue to then, you guessed it, check the patient. We would like to do the head tilt chin lift. We would then need to do the breathing check and the circulation check, and then we just act accordingly based on the 3 potential outcomes. Again, either the patient is unresponsive and they are breathing. If they are breathing, safe to say they will have a carotid pulse. I would consider putting them in the recovery position because we want to prioritize the patient's airway should they vomit at any point. Option 2 is we do the breathing check and we do the circulation check. Patient is not breathing adequately. However, they did have a carotid pulse. Therefore, patient is in respiratory arrest. If we have a back valve mask or a barrier device for breathing, we want to give 1 breath every 5 seconds for the next 2 minutes. 2 minutes later, you analyze again. Third final option or third final potential for that patient when we do the breathing and circulation check is that they are no longer breathing adequately and they also did not have a carotid pulse, which means the patient is still in cardiac arrest, which means we continue CPR until the AED automatically analyzes on its own every 2 minutes. Whether you get best case scenario, patient wakes up, or whether you get worst case scenario, patient still in cardiac arrest, it's important for us to leave the AED powered on and leave the AED pads on the patient. Remember, it's our job to turn the AED unit on and to put the pads on the patient, but it's not our job to take the AED pads off and turn the AED unit off. Reason being is, even if we get the result that we want, the patient starts to breathe on their own, the patient regains consciousness, that doesn't guarantee that that's where the patient is going to go for the remainder of the call. The patient can very much go back down, so that's why we want to leave